I'm going to be really quick. I talked to Mercedes Elizalde, who many of you probably know, a while back about trying to figure out how to connect more of our Measure 110 providers to somehow the new benefits that are coming out for Medicaid expansion. She recommended I talk to Carly because they're doing something similar in a very parallel space. Carly and I spoke, and it felt like there are some great opportunities for a lot of the services that you all are doing, where we could maybe, even if you're not somebody who bills directly, they can actually be a go-between potentially and help. So I'm not going to make more statements on their behalf because it's their work and I'll probably misrepresent it. But I'm really excited that y'all are here, and this is really meant to be a kind of for them to tell you who they are and what they are, and then to be able to ask real questions about clients that you interact with to see if this is something that could work as a partnership for your organization. And this is the beginning of a conversation, and so we just wanted to get it started. So I'm going to pass it over to Carly.
Thanks, Tara. That was a great introduction. And hello, everyone. Really nice to be in space with you this afternoon. I agree, it does feel like a Friday, even though it's Tuesday. My name's Carly. I use she, her pronouns. I'm the CEO at Project Access Now. And we will get to share quite a bit more about the organization momentarily, but I want to have my wonderful colleagues who run the work that I'm going to share a little bit about introduce themselves. So Myrna.
Yeah, hi everyone. My name is Myrna Valdez, pronouns she, her, ella, and I'm the Director of Programs and People for Project Access Now. I'll pass it to Sandra.
Hi everyone, my name is Sandra Rivera. I use she, her, ella pronouns. I'm the Community Assistance Program Manager for Project Access Now.
Great, thank you both. And they have the key to many of the answers and or questions that you may have this afternoon. So I'm going to do kind of a brief overview of the organization and some of the, I think, policy changes that we're seeing, which initiated Tara's request, just to kind of level set. And then Myrna and Sandra are going to share a little bit more about the specific program that is an opportunity for partnership. And we're going to open it up for questions. So I think we probably have, I'm hoping, no more than 25 to 30 minutes, probably 25 of content here. And I'm happy to share the slides after. So we're going to share about PANOW, consider the shifting policy environment and opportunities for more efficiency together today, explore potential collaboration with you all. And we really like to build relationship with folks when we're sharing more about the organization. So please put questions, thoughts, interactions in the chat, and use the interactions buttons that we now have because of the pandemic. So Project Access Now as an organization, or PANOW as we might refer to ourselves, is an organization that's existed for about 2 decades in the Tri-County area here in Portland. We were founded by the health systems largely back in 2007 to support the uninsured folks in our community, of whom there were quite a bit more than there are today. A lot more folks have access to coverage, which is wonderful, but we know that still does not mean access to care necessarily. So our vision as an organization is healthy communities where everyone has the care and services they need to thrive. We do this by partnering with community, with partners, with our community members, and with our health systems to create more equitable access to whole person care and social services. At the same time that we really strive to advocate for systemic change that would work us as an organization out of jobs. We would love to not have to exist as sort of a patchwork member of this quilt. Our values are collaboration, community, creativity, integrity, and racial equity. So as an organization, we offer kind of 4 buckets of work. The team, and you have 2 of our amazing team members here today, often very reflective of the communities that we serve. They create a really safe space for individuals, many of whom are undocumented or have been historically harmed by health systems, to re-engage or interact with the health system in a way that is safe. They provide culturally responsive support and do a lot of kind of screening and eligibility assessment to really understand what folks might qualify for based on a variety of factors. We provide healthcare insurance, whether that's signing people up for Medicaid, helping them understand how to use their benefits. Signing someone up does not mean that they're necessarily going to know where to find a provider or how to engage with a provider, like many of you. And so we are kind of in the background helping folks understand how to access their providers. And then for folks who don't qualify for Medicaid or a marketplace plan, we can pay the premiums for them to actually be able to enroll in a marketplace plan and stay engaged in the health system. And then through all of this, and I'm sure I'm preaching to the choir, we do a lot of health system navigation. So on the phone with providers, on the phone with billers and interpreters for the languages that we don't offer, really trying to get people into as much healthcare support as they can access. And that often is not a one-off conversation. That might mean that our team is interacting with a variety of different individuals and over a long period of time. So we're in some ways providing case management or care coordination for those folks. And then this last bucket of work is the one that's really exploded because of the policy environment and because of the needs of our community and our health system. And this is related to non-medical resources, but those that we know have an impact on health outcomes. And so we work really closely with community partners, the health systems, the federally qualified health centers like Outside In, to provide social needs screening, procurement of things like hotel rooms, food boxes, gas cards, transportation passes, and then pay for those services on behalf of a health system or a community partner and bill the right infrastructure. So that's largely what we're here to talk to you about today. Our community partners are vast, and some of you might see yourselves reflected here. Again, I'm happy to share the slides after so you can take a closer peek. But being around for 2 decades lends itself to needing to develop close partnerships with community organizations, and we're really, really proud of these partnerships. The health systems that we have worked with that founded the organization have invested over $50 million in the organization over the course of our existence. And I like to call this out just because it helps to show the investment that they have had and to highlight that it's not a small commitment to the community that the health systems have made. They don't do everything right, but they have invested quite a lot in our organization. I'm not going to spend a ton of time here, but we are, through the work that we've done over the last 2 decades, we have been able to process a lot of requests, help a lot of community members with services that are non-medical. I mentioned transportation related to food insecurity, housing, medication. And that has resulted in us helping our hospitals avoid people being unnecessarily discharged or being readmitted to the hospital to the tune of many hundreds of $millions. We know that that's where folks are sent when they don't have anywhere else to go, and a lot of the clients that you serve may end up in this situation. And our goal is to partner with you all to make sure that we are avoiding that as much as possible, and not just because of the cost savings, but also because of the sort of moral imperative to keep people where they are. We also know that it's really difficult to, it takes a lot of time, I should say, to support getting someone a Medicaid eligible service. And that's where we like to step in and be able to offer kind of a brokering between partners and Medicaid payers. Common examples of what's involved in this work for housing specifically, and I'm not talking about food, transportation, or any other domain, means that we're often dealing directly with hotel owners or companies, on the phone with landlords or property management entities to make sure that they are getting rent checks or payment secured to ensure someone can stay housed. Arranging and paying for improvements to a home to make sure that someone can either leave a hospital or have something done to their home to make sure they can stay housed. Obtaining IDs for rent eligibility or making sure that debts are addressed so that folks can stay housed. And a lot of this requires really quick timelines, right? To make sure that people avoid eviction. And so we have to be on our toes. Sandra's team is, on the phone pretty constantly all day addressing challenges to make sure that folks get what they need in order to keep them housed. So a lot of people think, oh, I'll make a housing referral and it's done. And this is meant to say, and again, I'm sure I'm preaching to the choir here, but this is meant to show that it's much deeper than that. And we try to communicate that often specifically to health systems. This is just to share also, I think there's been an explosion in technology and using technology to make referrals, and that is wonderful. We need better technological infrastructure, and the technology itself is not going to solve the social challenges that our society faces. And so we need the humans. We need Sandra's team. We need the people behind your organizations that are helping individuals who are slipping through the cracks. It can't be merely a technological platform that solves the challenge. So I'm not going to spend time on this slide because Sandra is going to talk about the program, but we are a broker of sorts. We sit pretty squarely between vendors, community-based organizations, local businesses that have something to offer or are serving clients, and payers who have resources that they need to get out the door. That's in essence what our kind of health ambassadors or navigators are doing. The policy environment is wild right now in this space. There is a huge interest in spending money upstream on non-medical factors, specifically through the 1115 Medicaid waiver. It's fairly wonky and I think pretty confusing. And so we're doing our best to stay kind of abreast of what we can. But we also recognize that things look a bit like a mess, like this chart on the bottom. Everyone is making referrals to random people. The wrong people are paying for the wrong things. There's minimal efficiencies leveraged. And so our hope is that we try to create a better infrastructure organizationally to support efficiencies and kind of relationships across these systems. This is a depiction of our experience as an organization in the investment in these non-medical resources. And this is just through our organization. We have seen a substantial climb in the amount of dollars that Medicaid and hospital systems are interested in spending on things like housing, food, transportation, et cetera. So, and this has been how we've kind of operationalized this program and built infrastructure underneath it, is the demand that has been placed on the organization. But we need to be, as community partners and providers, we need to be really organized in how we approach this work. And I believe there's a lot of strength in more sustainable funding mechanisms, valuing the expertise of community-based entities and providers, strengthening our social delivery system, not just the health system, and then leveraging things like technology and data, elevating the voice of those we serve, and providing support to one another in terms of how we learn together. So I think this is kind of a model of how we see ourselves sort of there in the middle, doing some management and coordination of health-related service dollars. We work with the payers, and I think on a different slide I have the health systems and payers that we have contracts with. But we would like to see a space where a client may be working with a partner who identifies a specific social need, maybe housing, and that partner knows that they can send that person to Project Access Now to help get low barrier housing, not necessarily housing case management. We're never be able to do that as an organization, but maybe someone just needs rent support, or maybe they need utilities taken care of. And the partner doesn't know who their payer is, doesn't know who covers them insurance-wise. Our team could figure that out, do an initial assessment, pay for that resource, bill the right partner, and make sure that you as a community-based organization or provider can focus on the work that you do best, which might be case management or a different type of service, not necessarily cutting a rent check to their landlord. At the same time, you'd be able to keep funds that you might be using on rent support for something else, and we would be leveraging the right payers, Medicaid specifically, for the services that they're now offering. This is another depiction of that, just a better way to access some of these resources as they become newly available. In the policy environment, this again has been kind of a sea change in the last 5 to 10 years, and we would like to see improved access, not just to clinics and medical providers, but to a variety of different partners around the region who are serving the same clients. So I'm going to stop there and have Sandra share a little bit more about how the kind of payment piece actually works, and then we're going to shut up and hear from you. So Sandra, I'll turn it over, and just tell me when you want me to move the slides.
Okay, sounds great. Awesome. Well, how does it work? It's very simple. We partner with local businesses and community-based organizations. They contract with us to provide services to community members. Our health systems contract with us to be able to access our network of community partners who then provide resources requested for their patients and their members. We find the resource, we take care of the billing, we provide payment to the community partners in a timely and efficient manner using a voucher system. We also provide technical assistance. We're available Monday through Friday, 9 to 5. So we're available for partners, for our vendors, just ensuring that our request gets completed and taken care of accordingly. Next slide. So the request process, your client has a need, how do you help them? So your team must identify the patient need and then submit a request in our internal system, which we are utilizing TrackVia. We then receive the request and work on it. Most requests are completed within 1 business days, unless more information is required or more follow-up is needed. In that case, we will contact your team to make sure that we get that information that we need in order to complete the requests. But some requests are approved automatically, and they generate a voucher that the client can use in real time. And so in turn, this allows your team to be able to return to your day-to-day work, knowing that clients are taken care of by our team. Once the request is complete, we will let you know by marking it complete in our system, which then notifies you. And then next steps. So the client utilizes a voucher that was generated by our system and gets help immediately. So for example, if it was a transportation voucher for the client to go from one place to the next, they would use a taxi voucher, or if they need a place to stay, then it would be a hotel voucher. We take care of all the contracting and maintaining the relationships with our network of community partners. We're always looking to expand that list. But we usually get invoiced from the vendor or community partners who provided the service, and then we pay them within 30 days of receiving that invoice. Lastly, we also bill this health system for the goods or service, and then follow up with any necessary documentation. And then for data and reporting, we collect the data and provide that for every service request that we do. The reports are driven by the system and what your team needs are. And again, what our goal is to remove the administrative burden so that our partners get paid quickly and that our health systems aren't tracking things down, and they can just focus on the work and make sure that the requests are completed in a timely manner. So again, our goal is to ensure same-day completion, and depending on the request, many of them are straightforward, but sometimes we do need additional information to be able to complete. But about 80% of them are done within the same day. And usually the ones that are taking a little bit longer is because a lot of back and forth information might be needed to be able to complete it. But our goal is to ensure that we make sure we complete that request as timely as possible. And this is a list of the services that are available. This is not the complete list, but transportation, housing, and food tend to be the biggest heavily requested items by our partners. For transportation, our partners utilize a lot of vouchers, especially to get from one place to the next. Our partners also order TriMet tickets in bulk for them to distribute. For housing, we do a lot of short-term stays with hotels. We pay rent and utility. We also purchase a lot of things, and so online like Amazon, Target, and all those other places. They're our best friends sometimes. And then for food, we have meal vouchers. We have community supported agriculture organizations that we partner up with that provide fresh produce. And then there are some other items in here that, some of the things that, our partners ask, we haven't really worked on, but our team is always open to looking at alternatives. Whatever our partners are asking for, we try to seek out and make it happen. And whenever possible, we tend to partner with local community organizations to support small businesses, women and minority-owned businesses, and of course, to be able to help our community out as well as our clients.
Awesome, Sandra. Thank you. Myrna, I don't know if you have anything you want to add before we open up for discussion.
No, I think you guys have covered it all.
Awesome. So I prompted with a couple of questions, but we don't have to follow this. Very curious what questions you have for us, and probably ultimately for Sandra. But yeah, the floor is yours. And I don't know, Tara, if you wanted, do we have hand raising mechanisms, like what the best way is?
I think we should do hand raising, and maybe if we move back to the room
Full
with
screen. Yeah.
That's the word I was looking for. But then Devin has it just us.
I can spotlight or not spotlight anyone. I have so much power.
You have so much power. I'm down with not being spotlighted, but it doesn't matter. Does somebody want to kick off with a question for these folks? I thought it was really exciting. So I could be off, but Dina and then Jack.
Yeah, we receive, I'm sure that some of the agencies that you're already partnering with, we receive payments for rent from you all for some of our participants. What is the process to create the partnership?
So usually our health system partners or community organizations, they tend to reach out to us, whether it's through email or through a call, just letting us know that they're interested in being one of our partners. We typically share the workflow of how our voucher system works. And then we send over paperwork for y'all to review. And then, of course, if there's any additional questions after that, then we hop on a phone call or a Teams or Zoom's meeting. But it's pretty simple. You know, the benefit of being part of our partner network is our partners are able to see that list and utilize you for whatever resource that they need for their client. So it's something that it's definitely a great benefit apart from, you know, getting paid in a timely manner and just simplifying one contract versus being able to be, you know, individually contracted with each partner.
Right. Most of our houses, we have 22 locations. A majority of them are funded stays, but our people need other services that you provide also. And we also do aid and assist. So are you guys gonna put someone's email in the chat so that we can reach out to you?
Yeah, I can definitely do that.
Fantastic. Thank
Zena,
you, ladies.
this may not be relevant, but I'm wondering before we move to Jack and Melly, is if even though some of your houses, let's just go with the 110 houses are funded, if you could get the funding through Project Access Now, then couldn't you then use those 110 funds for other things for clients?
I don't know. I don't think I could ethically do that.
I don't mean unethically. I mean more in terms of as we're looking, here's the way I was thinking about it, and I could be wrong. As
Okay.
we're looking to a new RFGA for 110,
Mhm.
you have housing where you pay for the person up to 6 months or whatever it is that you applied for. I'm
Right.
using you as an example. But if there was a way, and it would be as understanding this partnership in a much deeper level, but if there was a way to then say, okay, I can free up those 110 funds to now either start a new house, offer new
Well,
stuff.
that would be absolutely amazing. I just don't know that OHA is gonna co-sign that one.
Yeah,
I would love to be able to do that because then I could create more housing. That's a good idea though.
so I think we just need to explore that for the next round of grants. That's why we
Yeah.
want to have this conversation as one of the things is 110 paying for housing that we could be getting Medicaid to pay for, which I think the answer is yes.
Yeah.
And therefore we would have more $110 to do other things. And I don't mean that in a shady way, just we could utilize our dollars better. And I think that what I was so excited about Project Access Now is that they're kind of that admin hub that so many of our, you know, providers just don't have and maybe don't need because they can
Right.
provide that support. So that was an idea. And I see Carly shaking her head. So I don't think I've like stepped on too many.
No, I mean, there's definitely the workflow, like how would we workflow this to make sure that we're clear around eligibility? But because the whole policy environment has changed, even people leaving the hospital systems right now, 40% of them are Medicaid eligible, and the hospitals are paying for their discharge plans when Medicaid should be paying. So I think it's just this massive shift that has happened, and we're not yet aware that frankly, OHA would sign off on it because it's allowed.
So we got more work to do, but I think that this is why the partnership to me made so much sense and an idea that we might be able to stretch our $110 if a lot of the new Medicaid eligibility would cover this, and that's too much of a burden for our providers to set up the billing departments. But if there is this intermediary how could we be working through that? Okay, Jack and then Melly, sorry.
No worries. This is very exciting, like as a small community-based organization with like an admin team of 3, one of whom is our executive director. Like this sounds incredible to me. I have a couple of questions. One is probably pretty easy. Is just do participants need to already be enrolled in Medicaid to work with you all, or is enrolling people in Medicaid something you can assist with? And then my other question is, like, say every Measure 110 provider in Washington County wants to onboard with you guys, like, what's your capacity for that? Like, are you ready for all of us calling you and like wanting to get on board? Just curious about that.
I can take on the first one if you like. So in regards to having to be Medicaid eligible or helping clients enroll in Medicaid, this specific program doesn't help enroll clients in Medicaid, but we do have other programs within Project Access Now, including one that specializes in helping clients enroll in OHP and QHPs. So the gist of that is no, they do not have to be enrolled in Medicaid. Although I will say that currently the way that our funding is set up for this program specifically, we're a closed loop program. So the clients, depending on what funding bucket we're pulling from or what partner, in this case, the CCO, they do have to be enrolled with that CCO.
But I think to make it simple for you all as partners, you would just have one entry point to PANOW where you would say, I need this person has been screened, they have a need. I don't know who their CCO is, if they have one, or I don't know if they have insurance. Can you work with them? And we would work on our end to say they get to the right team who will get them signed up for coverage, and then ideally submit the request for the tent or the food or whatever it is that they need. And then I think I can take the second question, Jack, around capacity. I think on this set, we're always assessing capacity. And I think because of the environment, this is likely to grow. But our commitment and our vision is to community. And so I think working with our community partners to understand how many folks we're talking about, how many entities need the help. And then working with our health systems to say, hey, demand is really high. We need more resources to be able to do this, is part of us acting as that broker. So I wouldn't say you shouldn't worry about too many people calling us. We would rather have too many at this point than people not getting helped.
Melly.
So I'm similar boat as Dina. I have many recovery homes throughout Portland Metro, and we receive a lot of checks with your logo on it for people's rent. And I had always assumed that that was flex funding. It's not?
It is flex funding, yes.
Okay, so that's my first question. My second question is, so if we become a partner with you, because normally when I have a resident in need, I'm like, well, you need to go see your treatment provider, you need to go see your doctor, you need to go see somebody to apply for flex funding. Is there a way for me as the housing provider to, contract directly with you to ask for these people's assistance so that they don't get displaced?
I'm looking at my team. I'll take that one. Yes. Again, the whole point of this sort of front door hub administrative support mechanism that we want to provide is that you should be able to focus on the work you need to do, not helping them navigate a really broken health system. So ideally, you are sending them to us. We're doing these screenings for what they're eligible for. Depending on how close our relationship is with a partner, we may have case conferencing calls where we actually have to work through things with a specific partner. But you're hitting the nail on the head. You should be able to refer, and we should be able to help them do kind of the health care side of navigation.
Yeah, I was just trying to find an easier way sometimes. So sometimes these people have already completed treatment because our housing doesn't have an interim, but they've fallen on different times or different things have happened in their life and they need some assistance. And instead of me sending them over to start a new caseload with somebody or to go getting in to see your primary care sometimes is months out, you know, and so if there's an easier, quicker way for me to get my residents in to get this assistance, I'm all ears, and please sign me up.
Yeah, and we can't, I mean, unfortunately, I wish we had a wand and we could fix the access challenges around primary care. Those are still going to exist, but what our team can do is give all the options. Like, here is what you could do in a way that I don't think, because they're experts in kind of a healthcare system, they have a lot of knowledge about what's available and what's not, including accessing the FQHCs. So I think, yes, I think kind of having us help figure out what options exist and how to pay for those is what we can
Now,
offer.
is there a different time for a turnaround for, say, a rent payment, depending on who their CCO is? Because I've noticed like things coming through, say, Pacific Source, are a lot slower than someone who has health share.
For as far as payment, it just really depends on when our partners submit the invoice over to us. So I think a benefit to being part of our vendor network list that we have, I think would help simplify that. Because instead of you sending the invoice to the partner, you would send it directly over to us. And as long as we have a request for it in our system, we're able to submit payment faster to you. If that's something that you would like us to work on with you, definitely send me an email and we can explore the potential partnership.
I'll do that. Thank you.
Thank you.
Wendy, I see your hand is up.
Yeah, I just wanted to clarify. So you're not currently accessing Medicaid for housing? Are you just flex funds and housing support, or are you a intermediary for other housing assistance? I was a little confused by that last answer.
Yeah, we contract directly with Care Oregon and Health Share. We're developing a contract with Pacific Source currently and Trillium to provide flex spending requests for housing related needs. So we've been doing that for the last, I don't know, 5 years, I think.
So
Right.
housing related, but not in like hotel, but not rent.
Rent supports included, utilities, hotel, motel, home repairs for homes for people who need them.
So how will the expansion then that includes housing that's effective November, how will that be different from what you have available now?
Yeah, it's a great question, and one that I really wish OHA was making more clear, because I think it is very confusing. So the flex request, health-related services, or HRS, those are sort of global, right? The CCO can decide what they want to spend. And they have a requirement to spend a certain amount. These new benefits under the waiver, HRSN, health-related social needs, just add an N and it's like a totally different pot of money. Those are, we're in a 5-year demonstration to look at benefits to specific populations. So that will actually be a smaller subset of this larger ability to spend money on health-related services. HRS is global, HRSN is, there's 5 distinct populations. They can only cover food, housing, and climate, which has gone live already. And some of the parameters are different, right? Like 6 months rent, that's not usual. That's not normal that the CCO would say, yes, I'm gonna pay that under flex, but they're gonna have to for these 5 populations under HRSN.
What are the
Yes.
5 populations, unless you already had said that?
I have not said that. I'm gonna have to go look it up online, but I can do that.
And were you done, Wendy? Sorry, I jumped.
Pardon me?
You done? Or did you have more? questions? Sean?
Yeah, thanks. The disclaimer is at the risk of sounding totally ignorant on some of these things, I'm going to ask a couple questions. And if if we take it offline, that's okay too. We're not a Medicaid provider. We don't bill for any of that. We do a lot of work with poverty issues around homelessness and food insecurity, and are active in that world in Western Washington County, including with on our side, we're coming into behavioral health from like funding from SHS, Supportive Housing Services, through Washington. And we're also I'm trying to watch also Washington counties gave us a big presentation at the HISN meeting around, I think, this funding source and how Washington County is going to be rolling this out for providers. And I'm trying to keep track of all that and understanding, as a non-Medicaid billing organization that has funding from SHS, OHA Measure 110, and then partnership in this space, wanting to take advantage of this source, trying to understand how those things all weave together, especially in the housing or the food or and again, at the risk of sounding just lame here, I'm trying to, how are you guys navigating the other kind of elephant in the room, which is supportive housing services across these 3 counties and the funding around, like you're saying rent, I'm like, great, but like there's a community connect point of entry that the county requires. Can we, like, is this avoiding some of that? Can we work outside of that to get people into homes and things and bill Medicaid for that? I mean, how does this work?
Yeah, Sean, you're not, I appreciate your vulnerability in saying you don't have all the answers. We don't either. It's very, very confusing. And every meeting I'm in, I feel like there's the same questions and swirls. So keep asking questions. I think it's smart. I would say at a global level, and I know in Multnomah County, the coordinated access point is also going to be serving as sort of a housing hub for some of the waiver dollars specifically. What we're trying to do is offload the low-hanging fruit, right? Like the rent check that we can easily cut, the utility support, things like that don't require a lot of specific case management, to just get that out of the fray so that housing providers and behavioral health providers and others working with communities needing housing support can focus a bit more on the work that they should be doing, which isn't administrative in nature. So we're seeing this as like an add-on to the services that exist, and maybe a way to say, okay, we've paid for 6 months rent for Joseph. Now we know that's going to run out really, really quick. How do you then build your permanent supportive housing funding behind those 6 months with case management support, but you don't have to worry for those first 6 months? Trying to kind of braid and blend where possible. And the other tricky thing is it's going to look different in every county. Unfortunately, there wasn't a kind of global tri-county area effort, which I think is a misstep, but that's my soapbox that I'll step off of. But yeah,
will that help? I mean, this is not a hypothetical, but a rhetorical. Does that braid and blend well with a housing waiting list that they're sitting on with the county? Will it violate those? Will this, these helps violate a process they're in and get them out of line, so to speak? So again, we're coming from some housing and case management side of question. But we're also now in the middle of behavioral health funding and getting transitional housing built here in Forest Grove and things like that. So just trying to keep track. I guess when at the HISN meeting, if anyone attends that, I don't know if anyone in this room goes to that meeting, but the county's talking about, there's $1 billion available, and this is what the county's going to do to get providers in the loop on housing providers in the loop on these funds. And so I'm just trying to marry these ideas. And I think what you're providing here is amazing. Don't get me wrong, but
yeah.
The other thing I'll say rhetorically is maybe I'll follow up with a one-on-one sometime, but the connecting the dots, can we be a provider and or can we be a provider for that and then that's the deal, right?
Yes.
but shoring up, this is gonna sound terrible, I'm the ED of those, shoring up admin dollars. I don't know how Medicare works to actually help support the organization to do this work, or if it just provides for the services. So that could be rhetorical as well, but I need to understand better how Medicaid works and the billing for that process, or how we can, I don't want to, of course, I'm not making money off this, but we do need to keep our
Well,
state
I
above water.
think that's the thing that we're trying to offer is, and maybe we should follow up offline, Sean. I'd be curious about the housing specific questions you asked, but I don't think it's operationally wise for all of us to develop billing infrastructure to bill Medicaid. Like that just is not smart, especially for smaller organizations. So what we're trying to say is let us be the plumbing that can help you get that money, that allows you to turn on a faucet when you have a client who's Medicaid eligible and turn it off like you would your water. We can work directly with the payers to kind of build that infrastructure so that you can just access the resources. That's some of the premise here, and that's evolving in multiple regions around the country where there are hubs lifting up to say, hey, this doesn't make sense for everyone to do. Let's centralize a little bit.
And that was kind of the crux of our conversation was there's a lot of 110 providers, community-based providers who probably don't need to get have a Medicaid billing service in their own organization. And we don't even know how many folks like are eligible for this benefit or would be able to utilize this before we start asking everybody to go learn Medicaid and figure out if they should be getting a billing department. So it feels like what Project Access Now is providing is that hub so that you don't have to become a Medicaid billing entity. It's more collaborative and collective than we're used to. But that's really the system we're trying to create, and that's what 110 is also trying to do. So I think that after Carly and I spoke, it was exciting for those pieces. Is like, could you feed into that in a way that would help free up more dollars to be able to help more people? And Devin, I see your hand is up, and so is Wendy's.
That is not actually me. That is someone posing as me.
Oh, who is that? Is that Shannon? Is that you?
That I don't know if I'm posing as, is that me? Is Devin?
Yeah, you're going in as Devin. You're undercover.
Oh, I don't know how that came out to be like that, but so I'm Shannon, and I'm with Women's First Transition and Referral Center, and we work to serve women transitioning out of prison and recovery from addiction and recovering from other trauma, helping them to overcome their obstacles so they too can also become successful and productive women of our society. We have one recovery home, and we work with women, and we have 3 beds for recovery, 3 for reentry, and 1 bed for emergency housing, which is a mix of domestic violence and homelessness. And we're looking to hopefully soon get another house here soon for respite care for women up to 90 days until we can get them into treatment. And so we're celebrating 7 years this year of the work that we've been doing since 2017. And so I most definitely agree to this model. I've actually did a little bit of a kind of similar model with the, what was it? The housing benefit program with Health Share and I think it was Oregon Health Plan or something. I think you guys know what I'm talking about. And it just didn't work out. It went for a whole year. Then they condensed it down to 6 months, and then it just kind of dwindled away. They ended the program, I think it was last year on June 30th of 2023. The challenges that we did have, because we was most definitely a partner to that program, is because there was a lot of people that was upfront getting the services that was provided. People was, knowing that they were getting their rent and stuff paid for a whole year. There was a lot of different partners that was available, that was working. We had a lot of meetings every month downtown. And the thing is that when we were getting the referrals over to our agencies, it was the fact that we kind of kept going back and forth with the the what was it, the OHA, the health share team, because the people that they were sending to us didn't want to participate in none of the wraparound support services that we had. So of course we had, our Ready to Rent, we had the Know Your Rights workshops, we had Skills for Life. There was only about 3 classes that we had them, to do, and people they didn't want to participate because they've already known that they were going to get their rent paid for a whole year. And so for us, my question to you all is, as you looking to work with, like you were saying, Cowardly, about just, kind of working with hand in hand with you guys to allow us to be the provider, you guys to be the resource to kind of help us for hand in hand. After you, because like Dina was saying in the beginning, a lot of our organizations, we do have kind of like, we get funded to be able to give rent assistance, utility assistance to maybe not just one grant, but maybe a couple grants and stuff. And so with this opportunity here, how would you all, as far as when you're looking at technical support, being able to work with agencies such as ours, we're a small organization, and looking at, say, if you have a person that you're working with 6 months and you're looking at to help develop a housing provider, when you're looking at technical support, how would you be able to work with that, assessing a small organization as trying to help as far as looking at that infrastructure and helping with, continue on with looking at the resource side of things, to more or less of helping us as we're looking as a provider, but then also looking to switch it to become that, as we're looking to switch the roles as becoming that resource. You see what I'm saying? But then working with us as a hand-to-hand. Okay, so you're starting out as a housing provider, but now you are, as we're working with you, here it is, you're at the 6 months mark. Now we're coming back in to assess to see how you've been working with your participants in this role as the provider. Now we're going to assess you to see how things work, what's working, what didn't work. Now, what would that look like, as far as we're working with you all as partners, not only just to be able to provide that housing for the folks that we're providing housing for, but as far as really kind of digging into a dive and going a little bit more as providing housing, but becoming as that resource to the partner participants that we're working with.
Yeah, thanks, Shannon. I appreciate the question and also your experience with Health Share and the housing pilot. We were working on that last summer as well. I think, a short, quick answer, because I know we're over time. I think we are very much in a learning phase and really eager to figure out with partners how we develop role clarity around what we can offer that supports your work and really lifts you up as the service provider. Again, we're behind the scenes infrastructure. And then what is our lane that you want to offload or you want us to help do so that you can focus on the work that you do. So it's a learning experience. This is a new space. It's pretty cutting edge, and I am eager to hear. I know Sandra put her email in the chat. She is absolutely the right team member to follow up with on next steps. And I wonder, Tara, too, if you have any thoughts on additional next steps.
I mean, thank you for joining us. I think this was really helpful, and I think we should continue to host these, or even just kind of host a space to ask more questions as they come up. But yeah, I think the first round is reach out to Sandra if this is something that you are interested in. And then we're also going to make sure that we send this around to all of the Tri-County Burn participants so that they may also have more questions and maybe Sandra, we can work on an email intro that we can share with folks on that list so that they know how to reach you. And then we can just connect again. You know, I think if we can have this space open for a couple months, we'll get more and more people will understand kind of what you guys are able to do. And then you'll understand what the need is in this space. Because I know behavioral health hasn't necessarily been the space that you've been in. And I know that there's a lot of providers that wanted to be here but couldn't too. So Shannon, reach out to Sandra is my recommendation. And anybody else who wants to jump in, and please reach out, and then let's figure out what else is helpful to continue this partnership. But I really appreciate you guys being willing to jump into this space with us and figure it out. And I think that there's a lot of really great room here, especially with the new grant coming out at the end of July, so allegedly. We can figure out how to maximize those dollars, the Measure 110 dollars for sure.
Thank you for putting this together, Tara.
Thank you, everyone.
Thanks, everybody.
Thanks for having us. Have a good day.
Thank you, Tara. Thank you, guys.
Thanks.